Cardiac CT and coronary anatomy. Conventional coronary angiography is the standard of reference to evaluate the coronary vasculature. However, now we have a non-invasive technique, the coronary CT angiography, that will allow to evaluate the coronary vasculature in a non-invasive way with great anatomical detail. When we talk about coronary anatomy, we need to know that on the right side we only have one artery, which is called the right coronary artery or the RCA. And on the left side we also have a left coronary artery, which has different parts. It starts with the left main and then will divide into the left anterior descending coronary artery and the left circumflex coronary artery. Here you see very nicely the right coronary artery, the left main, the left circumflex, and the left anterior descending coronary artery. The nomenclature that we generally employ to call the different coronary segments is based on this classification published in 1975. For this purpose, we usually divide the RCA into the proximal, mid, and the distal RCA, and the distal RCA will give off two branches, the posterior descending coronary artery and the posterolateral branch. Generally, the acute marginal branch is what will divide the proximal and the mid segments, whereas this angle is when the mid segment will turn into the distal segment of the RCA. In the left coronary artery we've got the segment 5 or left main, and then we've got the proximal, mid, and distal LAD. The LAD gives off diagonal branches. Here we're seeing one diagonal branch. This patient only has one diagonal branch. The transition between the proximal LAD and the mid LAD is usually even the first diagonal branch or the first septal branch. Then we've got the distal LAD, which the transition between the mid and the distal, some people say that will be the takeoff of the second diagonal branch, but generally speaking, what we do is we divide this entire length in two. So we've got the proximal would be the mid diagonal, mid LAD, and the distal LAD will be the distal part. The circumflex artery, it has two segments, the proximal circumflex and the distal circumflex, and it's divided by the obtuse marginal branches. Acute and obtuse, the names of the marginal branches are due to the acute angle of the heart or the obtuse angle of the heart. So this is the most generally employed nomenclature. If we want to use a specific nomenclature for cardiac CT, we can use this one proposed by the Society of Cardiac Computed Tomography. This SCCT coronary segmentation diagram is very similar to the other one, but what we need to know is that what we're doing is like if we were compressing the heart. So here you've got the RCA, you've got the left main here, and you've got the LAD here, and the circumflex artery here. So again, we've got the proximal RCA, the mid RCA, the distal RCA, the posterior descending artery, which is called segment 4 if it's coming from the right, or it's called segment 15 if it's coming from the left. We've got the right posterolateral branch, which is the most common one, and this is segment 16. The left main gives off the LAD and the LCX. The LAD also will give the first septal branch, another diagonal branch here, first diagonal branch, mid LAD, second septal branch, second diagonal branch, and distal LAD. So again, what takes off earlier, the first septal branch or the first diagonal branch will separate the proximal and the mid segments of the LAD. Then we've got the left circumflex coronary artery with the proximal segment, the first obtuse marginal branch, the distal segment, the second obtuse marginal branch. This is the normal coronary anatomy, and this happens approximately in 85% of the individuals. In 15% of the patients, we will have this branch here, which is called ramus intermedius, or the intermediate branch. And this is called segment 17 when we are talking about the SCCT coronary segmentation diagram. Whereas if they use the AHA 15 segment model, that would be segment 16. Anyway, so we've got from the right coronary sinus, we've got the RCA. From the left coronary sinus, we've got the left coronary artery with the left main stem. And then we've got the LID, the circumflex, and in 15% of the individuals, the intermediate branch. This is the same shown on cardiac CT images. Here we see the left main LID, circumflex. Then here we see the RCA. Segment 5, proximal LAD, mid LAD with the first diagonal branch, distal LAD with the second diagonal branch, circumflex, proximal circumflex, first obtuse marginal branch, distal circumflex, second obtuse marginal branch, RCA, mid RCA, distal RCA, posterior branch, posterior descending artery. So this is how we see the coronary anatomy on axial images. Why is it important to know? It's important to know the coronary anatomy because according to the coronary anatomy, we'll be able to determine the coronary artery territories of the myocardium. And we will be able to divide the ventricle in different segments, and each segment will be vascularized by a specific coronary vessel. We've got a 17 module segment, which is the one promoted by the American Heart Association and is the one that we generally employ in our regular practice. We've got the basal, mid, and apical segments of the left ventricle, which are divided in 6, 6, and 4. When we're talking about basal, mid, and apical, we've got the anterior, the anteroseptal, the infraseptal, the inferior, the infralateral, and anteral basal segments. These are divided by the hinge points of the ventricles. Here you've got the anterior and the inferior hinge points. So you think of a line crossing that, and then on the center of the ventricle, this is how you acquire 6 segments which are generally equal in size. And it's important to know this myocardial segments model and to match it with the coronary segment model. So the LAD territory is usually the anterior and anteroseptal, basal, and mid and apical segments correspond to the LAD territory. The infraseptal and inferior segments and basal and mid and inferior apex is usually the RCA, whereas the lateral aspect of the left ventricle is usually coming from, or its vascular is usually from the left circumflex coronary artery. So that's why it's very important to know the territories that are irrigated by the coronary vasculature, different coronary vasculature. This is generally speaking. There are of course anatomical variants that in the coronary artery perfusion territories that need to be known. However, as a general purpose, I would say that if we're talking about RCA, we need to think about the infraseptal and inferior aspects of the left ventricle. When we're talking about the left coronary arteries, we need to think about all the anteroseptal, anterior and lateral wall. This aspect is usually anterior anteroseptal LID. Lateral aspect is usually coming from the left circumflex coronary artery. Another important aspect of the cardiac anatomy for which we can use cardiac CT is to evaluate the heart valves. The mitral valve has two leaflets, one anterior and one posterior. The anterior is semicircular in shape, and there is continuity between the anterior leaflet of the mitral valve and the left and non-coronary cusp of the aortic valve, which is called the aortic mitral curtain. The mitral valve is very well visualized on CT. Here you see the anterior leaflet, here you see the posterior leaflet. And definitely we can also evaluate the subvalvular system with the anterolateral and the posterior medial papillary muscles. And there are chordae tendinae, or the tendinous cords, which are tendons resembling the fibrous cords of the connective tissue that will connect the papillary muscles to the mitral valve. So the mitral valve consists of leaflets, the anterior and posterior. We've got the papillary muscles, the anterolateral and the posterior medial, and there will be chordae tendinae that will attach these papillary muscles to the mitral valve leaflets. The tricuspid valve has three leaflets, the anterior, the septal, and the posterior. The tricuspid valve is rarely well visualized on CT. When we see this valve, the tricuspid valve, like in this particular case, we need to think that it's thickened and therefore it is diseased, as it can happen in the carcinoid heart disease, as in the example that I'm showing to you here. So a trick is that in conventional CT angiography, tricuspid valve is very rarely well seen on CT. If we see it well, like in this case, we need to think that it could be thickened. The aortic valve has the annulus, cusps and commissures. The aortic valve cusps are three: the left, the right and the posterior, and can also be called the left coronary, the right coronary, and the non-coronary cusps. When the valve is closed, this forms a sinus, the sinus of Valsalva. So conventionally, the aortic valve has three cusps: the left, the right and the posterior. Sometimes the aortic valves can be abnormal. The normal has three cusps. Abnormal cusps may have two cusps, and in this particular case we call it a bicuspid valve. Here you can realize that cardiac CT is a very good technique to determine the anatomy of the aortic valve and can easily distinguish between the tricuspid and a bicuspid valve. The pulmonary or the pulmonic valve has three cusps: the anterior, the right and the left. The normal valve area is approximately 2 centimeters square, and when in general, if cuffs are easily seen, they are likely thickened. Means that if we see very easily the valve, very likely it's diseased, similar to what happens with a tricuspid valve. This is a normal pulmonary valve, and this is a thickened pulmonary valve. Here you see that the normal pulmonary valve is very thin, whereas the stenotic pulmonary valve can be thickened, and in the case I'm showing to you here. Let's review the coronary anatomy with this case of a 55-year-old woman, an ex-smoker for 5 years, with family history of ischemic heart disease. She refers non-specific chest pain for the last 2 weeks. They performed an ECG and an echo which were normal, and given these symptoms, despite the normal ECG and echo, the referring physician requested a coronary CT angiography for evaluation. This is the case of the patient. A young woman with atypical chest pain. We're performing the coronary angiography to rule out coronary stenosis. We start with the RCA. You've got here the RCA. This is the right coronary sinus, the RCA coming down, right atrioventricular groove coming down, gives off branches. Now we will review all of these branches. And again coming down, and you will see branches down there. The first branch that we usually see from the RCA is this tiny little branch here. I'll do a MIP to see it better. This tiny branch, let's come in here, you see it here, or even there is another one a bit, maybe we can see it much easier here, coming down here. These are conus branches, and these branches are what they do is the vascularization of the conus of the infundibulum of the right ventricle comes out of the RCA. Is this first branch here. Then we've got more branches. This branch here is the acute marginal branch, tiny one. Here we see a bigger one, another acute marginal branch. So 2 marginal branches coming, and then we've got the distal segment of the RCA that will give off this posterior descending artery, which is the inferior interventricular groove, and the posterolateral branch. We see it here. In the volume rendering, we've got the conus branch here, diagonal branches. He's got this tiny little one here, this one which is bifurcating, and then in the inferior aspect we've got the posterior descending artery, and here we see the posterolateral branch. When we look at the left side of the heart, we see here, this is the left main. The left main is bifurcating into the LID and into the circumflex artery, and the LID, which is this artery, will give this one diagonal branch, second diagonal branch, and third diagonal branch. See that these go to the lateral wall of the ventricle. There will be also branches coming into the septum. There is one here and another tiny one here. Let's do a MIP to see it better. You've got a diagonal branch here, 1, 2, 3, 4. So see how many diagonal branches you can see. Here you've got septal branches coming into the interventricular septum. So sometimes it's difficult to determine what's proximal, mid, or distal. In my particular case, I would call this proximal to here, mid, and here with this third diagonal branch, and then I would call this distal LID. Let's look at this in the volume rendered image. Here you see branches that are coming to the septum. These are septal branches, like this one here, or this one here, and branches coming into the lateral wall, which are this one here, very tiny, and this one here. These are septal branches, these are diagonal branches. The circumflex artery is coming this, here you can find it very nicely, and the circumflex artery gives off obtuse marginal branches. Here you see the first obtuse marginal branch, here you see another marginal branch, it will be the second obtuse marginal branch. In the volume render reconstruction, we see the first obtuse marginal branch and the second obtuse marginal branch, and this is the native circumflex coming in the left atrioventricular groove. Here you've probably noticed another tiny little branch coming here. This one, let's do a MIP so you can see it better. This one, and this one is coming here into the interatrial septum. This is the sinus node branch. 60% of the cases comes from the RCA, 40% of the cases comes from the left circumflex coronary artery. That's the sinus node. So, reviewing the anatomy, we've got the RCA. The RCA will give off this conus branch, will give this acute marginal branches, and in the inferior wall it will generally give this, which is the posterior descending artery, and the posterior lateral branch. When we see this, so the posterior descending and posterior lateral branch coming from the RCA, this is a right dominant system. Other times will come from the left, this would be a left dominant system. Other times the posterior descendant comes from the right, the posterior lateral will come from the left. That's a codominant or codominant system. And sometimes there will be two posterior descending arteries. This is also called the codominant system. The LAD, again, left main, proximal LAD, first diagonal, second diagonal, third diagonal branch. Then we've got the distal LAD, and the circumflex artery will come here, will give off this first obtuse marginal branch, the second obtuse marginal branch, and this is the very tiny native left circumflex distal segment of the circumflex coronary artery. In the volume rendered image, again, the conus branch, the acute marginal branches, posterior descending posterior lateral branch, left main, LAD, the proximal segment, mid segment, distal segment of the LAD, proximal LCX, obtuse marginal branch, second obtuse marginal branch, and the distal LCX. So, with that, we've reviewed the coronary anatomy of a normal coronary CT angiography.